A 44-year-old woman presents with fullness in the medial aspect of the left breast. I am showing you the screening mammograms. Describe the findings.
Okay, looking at the images, the bilateral mammograms demonstrate scattered fibroglandular densities in both breasts. There is a subtle, ill-defined area of asymmetric increased density in the medial aspect of the left breast. No discrete spiculate mass or clustered microcalcifications are seen. The right breast appears completely normal. Given the patient's palpable clinical concern and the asymmetric density, this finding is suspicious and requires further evaluation.
Oh, I am now showing you the targeted ultrasound and contrast-enhanced MRI of the left breast. Describe the findings and state your primary diagnosis.
Well, the targeted ultrasound image of the upper inner left breast demonstrates an ill-defined area of architectural distortion. This area exhibits indistinct margins and marked posterior acoustic shadowing. The axial T1-weighted post-contrast fat-saturated MR image demonstrates extensive, ill-defined, inhomogeneous hyperenhancement in the same region. These multimodality findings are highly typical of invasive lobular carcinoma. Invasive lobular carcinoma represents approximately 8 to 12% of all invasive breast malignancies.
Explain why invasive lobular carcinoma is difficult to detect mammographically and discuss the specific role of breast MRI in its staging.
Okay. Invasive lobular carcinoma grows in an insidious single-file cellular infiltration pattern. Because it does not evoke a strong desmoplastic reaction or destroy the underlying tissue architecture, it often fails to form a discrete, dense mammographic mass. Instead, it frequently presents only as subtle architectural distortion or focal asymmetry, often seen only on a single view. While ultrasound is more sensitive, it frequently underestimates the true size and multifocality of the tumor. Breast MRI is highly sensitive and is mandatory for staging to accurately map disease extent and to evaluate for multicentric or contralateral disease, which is highly prevalent in invasive lobular carcinoma.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these mammograms with prior films to evaluate for newly developed or progressive asymmetry. I would suggest performing an urgent ultrasound-guided core needle biopsy of the left breast architectural distortion. I would recommend performing a complete bilateral breast MRI to accurately map the extent of the disease and screen the contralateral breast for synchronous cancers. Finally, I would document the findings, assign a BI-RADS5 category, and immediately refer the patient to the breast multidisciplinary team for surgical staging and oncology planning.